Well, hello and welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I'm your host, Shawn Needham, along with my wonderful wife, Janet. And today we are going to be discussing our takeaway from BHRT Uncensored, number one part, I guess. First ever. And there's going to be more to follow up. So it was a 3-day seminar where we talked about hormones. And those of you that follow Janet and I know that we've been compounding hormones and recommending hormones and talking about the benefits for almost 30 years now. And we absolutely love it because our patients actually get better. So we like to say that we're two pharmacists that don't believe in drugs to treat most long-term disease. And part of the reason is because we've seen the benefits of what hormones do to treat long-term disease. So Janet, what is your biggest takeaway? We're going to have a lot of them. So
We probably do.
There's not just one, believe me.
One of the things that I did appreciate about Neil Rousier, the physician MD that was giving part of the lecture, is that Neil went over and reviewed what a good study would be.
Yeah.
And that is something I think healthcare professionals have either not been taught or lost, or they're just ignorant on what's a good medical study. And I think that was very powerful because something might look like a good article to read, and just because it's in a big publishing group like JAMA or Lancet, that doesn't mean what was published was a good study. It could be just junk. It could be just somebody's opinion. And it's not that opinion could be wrong. That's not it at all. It's just like if you're looking for medical literature that is valid, you should have some criteria as to whether this is a good article, a good study, or is it worth even reading?
And he rated them from grade A to grade D, D being the worst. And, a grade A study is basically a placebo-controlled trial long-term with lots of patients. And there's actually very few of those. And partly because it's hard to get a lot of patients in the study, it's expensive. And then second of all, long-term, a lot of them drop out. So it's hard to keep them long-term. But, one of the red flags of any study is when the title says correlation or association. It just throw it out. Don't even read it. For instance, I'll tell you a story that I was taught in high school about studies. One of the best things I was ever taught about studies, and actually I'm writing about in my book, which is called Lies I Learned in Pharmacy School and How to Escape the Grasp of Big Pharma. I'll show you. Here's the book cover right here. But here's the gist of what my high school teacher taught me. He showed us a study where corn flakes cause cancer and Doritos prevented cancer. Now, mind you, this is in the 1980s, right? So who ate Doritos? Doritos had probably only been out, I don't know, less than 10 years. Mostly young people ate Doritos. Well, young people don't get cancer usually. And then who ate corn? Actually, I think it was what's the
shredded wheat.
What's the shredded wheat stuff?
Yeah.
I can't remember if it was cornflakes or shredded wheat. But whatever it was something that only older people ate because by then all the sugary cereals had replaced cornflakes, regular cornflakes and regular shredded wheat. So the study basically said that cornflakes cause cancer because people that ate cornflakes, it was had an associated risk of higher cancer. Well, just because something is associated with it doesn't mean it causes it. So that's a perfect example. And text lies to 833-495-3426 to get updates on my book. I'm looking at putting it out end of this year. So that's just a quick rundown on the study issue and how to look at a good or a bad one. Another takeaway, Janet?
Oh, man, there was a lot. Do you want to talk about thyroid?
Yeah, I'll mention it. I mean, one of the biggest takeaways, which was not revealing to Janet and I, because we've known this for many years, but we like to tell you guys as listeners and viewers, and just to educate people, that the standard thyroid test, TSH, thyroid stimulating hormone, is, I can tell you now after this conference, it's probably literally useless.
Right.
I mean, seriously, but that's the gold standard for testing your thyroid. And it's just almost useless. I mean, it might be a good screening at best to test for hypothyroidism, but for monitoring thyroid function, it's definitely not good, especially if we use the gold standards that the Endocrinology Society um, presents. What do you want to add to that?
I think endocrinologists really are undereducated because they still use the TSH, or they're biased because that's what they've known. Again, just to reiterate, lab testing is really important to have the right ability to read a lab. So it could be time sensitive. If you don't know how to read when a lab has been drawn and what that lab might correlate to, or does the lab matter to the patient? Like, is it important or not? The art of medicine is not treating a sheet of paper with numbers on. The art of medicine should be taking care of the patient and finding positive outcomes for that client. And many times in traditional settings right now, or the standard settings, most people, if they have the symptoms of being hypothyroid, like cold, constipated, heat insensitivity, losing their hair, brittle nails, they are usually undertreated because they're only looking at the PSH and giving them levothyroxine or Synthroid, and they're not giving them any of the active form of thyroid. So just, we went over other labs too, but how lab values mean things, but they don't always mean what we think they mean if we don't know how to interpret what is put in front of us.
Interpretation is so important, and because lab values can change, well, literally within minutes. But when you're testing most hormones, they can change dramatically within hours for sure. So it's important to know how to interpret that. Another thing I want to say, the takeaway of thyroid is there's just, and another lie I learned in pharmacy school, that T3, um, or thyroid in general, but T3 especially, is you got to really be careful with it because it's got a narrow therapeutic range, which means it can, the effective dose is too much and it can harm you, and too little and it's not effective. So um, and I learned that they give IV T3, intravenous T3, in for cardiac, to increase cardiac output for people in heart failure, and the dose is like 500 micrograms IV. And we have doctors that get scared of prescribing 50 micrograms or even 25 micrograms of T3. Well, if 500 micrograms of T3 IV doesn't harm somebody, tell me how 50 micrograms of T3, if they're doing well, if they're having, if their symptoms are controlled and they don't have like a racing heart, tell me how that's going to be super dangerous. It's a reminder of, I just have to relearn a lot of stuff that I learned in pharmacy school.
Right. And I think there's information that gets skewed. Where this information came from is actually looking at studies that of people who have Graves' disease. Well, you can't correlate Graves' disease to endogenous or giving somebody oral thyroid and put them in the same basket. And that's what we've done for decades. And so we have so many people out there that should be getting more T3 in their regimen to help them with their symptoms. And it makes a big difference. And the other lie they said is that too much T3 is going to cause bone loss. Well, I think there's other things going on with the bone loss.
And that's another one of those association studies. They associated T3 with causing bone loss, and that's what we learned in pharmacy school. But a lot of times the problem is those people were older and they were postmenopause, and they had low hormones like testosterone, estradiol, and progesterone that helps build bone. So was it those, or was it the T3? Was it lack of those, or was it the high dose T3 causing bone loss? I mean, so. Um, Another takeaway I wanted to talk about was testosterone and hematocrit. Testosterone causing thick blood, testosterone causing clots, testosterone, patients that are on testosterone that have a high hematocrit are told to phlebotomize if they have a hematocrit of over 55%. Um, and yeah, we've known that this has never made sense to us, but it really was reiterated this weekend that it's just silly. And there's some influencers out there. Peter Tia, he's a big influencer in the health and wellness space. He literally called doctors morons that don't phlebotomize their patients that have a hematocrit over 55 because it's causing thick blood and going to cause blood clots. And and what this means is that if you have a hematocrit over 55, they have you go give blood, and then it lowers your hematocrit because you have less blood and you have less um yeah, you have less blood volume, so then your hematocrit goes down. But here's the thing, then you feel like crap for a few weeks. Of course you do. Because what does a high hematocrit do? Well, testosterone stimulates erythropoietin in the kidneys to make more red blood cells. Um, and then you have a higher oxygen carrying capacity. You have better exercise tolerance. That's what makes people feel better on testosterone. Just one of the things. So when you go get rid of that and lower that, you feel like crap. Um, and remember, it's not the red blood cells or the high hematocrit that cause clots. It's platelets. And testosterone does not raise your platelet count. So if you're going to a doctor that is having you get phlebotomized because you're on testosterone, your hematocrit's over 55, you should probably think about getting a new doctor. Just saying.
Right. So the other takeaway about testosterone, and this is something Shawn and I talk about quite often, it is super helpful for helping with muscle mass as we age. Abdominal weight, we know, is a metabolic problem. We know that metabolic illness is what's causing the inflammation in the arteries. It's causing um, the increase of exhaustion, not being healthy, not having the desire to move, the brain health. I mean, we went over this many times, but many times it's very underdosed. And I'm not really sure why we are so afraid of putting something endogenous into our body versus giving a chemical from big pharma. We all are okay with that coming at us, but when it's your own endogenous hormones, we get really nervous, and that is something that Shawn and I deal with quite regularly on a regular basis because overdose or too much means that you're starting to have side effects. And that's rarely the case. Most of the time, we see patients that should have their doses more optimized, meaning, do you want to be as healthy as you possibly could be, or do you want to just have a crappy dose? And this happens to both men and women, that their physician is nervous about giving too much. It's not like when we're in the hormone space and we're trying to do replacement, we're not talking about guys in the gym shooting hormones up. That's not what we're talking about. We're talking about levels that help us maintain quality of life, um, and feeling better.
Yeah. Another thing I wanted to add to that is another takeaway that I got about testosterone is that it increases cardiac output.
Yeah,
And we shouldn't be
it's a
surprised. I
muscle.
mean, it increases lean body mass, striated muscle, so it helps your heart also. And there's other ways that it does that too. I think it's vasodilatory, so it dilates your vessels too. But think about this: how many heart failure patients do we have on these fancy drugs,
Mhm.
and they're suffering horribly? And thyroid, T3, and
Testosterone.
testosterone could help them. And by the way, they're cheap, but we don't do that. That's not gold standard. And you just wonder how many people, well, I don't know the numbers, but a lot of people suffer because of it. And the regular drugs, you can read some of the studies on them. Patients usually never get better. They usually never get better on those drugs. Sometimes they might maintain their cardiac output, but they usually don't improve. And that's kind of typical with all pharmaceuticals. And that's one of the reasons that Jen and I don't believe in a lot of them because we've seen the failures of them. How many times do people on a blood pressure medication come off of it and get better? Never. They're on it for life if they don't change their lifestyle with other means. Same thing with cholesterol meds. Statins were one of the first class of drugs that Janet and I ever questioned. How many of the patients ever get off statins? And how many people have heart attacks that are on statins? Over 50% of all patients that have heart attacks are taking a statin. They're not working. Janet?
Right. Thyroid and testosterone help improve the lipid panel if that's important to you, which in some ways it is, but definitely decreases the inflammation. And again, it's the inflammation that's causing the tissue damage. So why don't we fix the root cause? I mean, Shawn and I talk about this a lot, that many times we just band-aid a problem and we don't find the root cause of what's going on. And then once we do find the root cause, we undertreat. And I think that's one thing that's very hard to watch and see. We had a conversation about the hormone of progesterone. And right now, if your physician wrote you 300 milligrams of progesterone, there would be pharmacists and doctors that would be totally concerned.
Freaking out.
But that level of progesterone that a woman might need is anywhere from one side of the spectrum all the way to the other, depending on what her needs are and what we're trying to treat. So just because there's a product like Prometrium on the market that's for 100 milligrams or even 200 does not mean that that is the safe and only dose that's appropriate. I don't know of any other place that we do this. I mean, if you broke a leg or you needed morphine, they would never withhold, they would give you the dose that you needed to cover the pain, not to just, oh, well, we can't do that anymore. That's, I shouldn't suggest that. I'm sorry if I helped somebody in this in the wrong way. But my point is that you give the amount of medication to help treat the symptom that's in front of you. And many times with progesterone, we're just spitting it out, women.
Yeah, and we don't give enough. And speaking of progesterone, Janet, talk about what we learned about progesterone and breast cancer. And we've learned about this before, but
right. Well, they actually are using progesterone to help treat women in studies for breast cancer. And this is something that we've known for a long time, that it actually is protective to the breast tissue. So if we are using progesterone in women in studies to help with treatment, you got to know it's safe. And the other thing we know about progesterone is that as we age, and the earlier that we have children, which when we have children, our progesterone levels go off the chart, we know that the younger you are having children, the more protective progesterone is to your breast tissue. So just endogenous production in your own body is bringing safety to your tissue. And so women that have more than one child throughout their lifespan have a higher rate of, or a lower rate of incidence of breast cancer. So it, it's been vilified, and I've heard many women say, well, I can't have hormones because my oncologist told me progesterone caused the cancer. And I think they're just uninformed.
Yeah. And, let's just talk about that subject in general. We're taught that estrogen or estrogen in our bodies cause breast cancer. And think about how irrational that really is. You're telling me that as humans, we've thrived on this earth for thousands of years, and we were created wrong. We were created with a hormone in our body to cause cancer. Makes no sense whatsoever. Same thing as testosterone causing prostate cancer. It makes no sense whatsoever. And when do men get prostate cancer? In their 70s or 50s, whatever, usually when their testosterone is declining. If testosterone causes prostate cancer, young men, like 18, 19-year-old teenage men, would be getting prostate cancer, and they don't. And the same goes for breast cancer with women. Other than most young women in their 20s don't get breast cancer. If they do, usually you can attribute something. Many times it's birth control pills. And what do birth control pills do? Birth control pills decrease our own endogenous production of hormones, and they are linked to breast cancer. But typically, women do not get breast cancer in their earlier years, childbearing years. And speaking of childbearing, their hormones are off the chart when they're pregnant, and most pregnant women don't get breast cancer. So to think that hormones cause cancer is just, crazy. I mean, it's not rational at all. Oh, go ahead, Janet.
So we have to touch on estrogen in men. I don't know if you already said that.
Yeah, that was my next one. I
Okay,
have not said it.
so we have this idea that estrogens for women and testosterone for men. And I'm going to dispel this way. Women actually carry more testosterone in a healthy woman than they do estrogen. And it probably depends on the timing and also if she's pregnant. But still, when she's pregnant, she has a lot of testosterone. But men also carry estradiol. So, where I'm going with this is that we have a lot of people, influencers, uninformed providers that give estrogen blockers to men because that shouldn't be safe for them. Well, actually, it's harmful to take the estradiol away from a man because he needs it for his brain, his vessels, his prostate. He needs it for his body to be healthy. And we know if you look over the time span of bodybuilders and athletes that have misused and have used blockers, or people who use the blockers, they end up with cardiac events as a side effect. So if your physician in PA or ARMP is prescribing you an astrazole or an estrogen blocker, you need to stop it. And I personally would never want anybody in my family to be on one of them. And it's still held over from, I'm just going to say it, from the gym, from guys,
Yeah.
deciding that they had man boobs. Well, the reason they're having that is because their hormones are going up and down and all over the place. But if you are on one of those medications, you need to talk to your provider and find a way to have that removed from your regimen.
It's you're setting yourself up long term for cardiovascular risk, heart attacks, if you're taking an estrogen blocker. It's just no need to do that.
Right. And the other thing too that we talked about in this subject is that it is a cause of erectile dysfunction.
Yeah, exactly.
So the side effect is affecting the blood flow to men, and that is harmful over time. And so sometimes when we talk about erectile dysfunction, we have to look at what's in the regimen of therapy. I mean, we always talk about the cardiovascular part or other part, but coming from the pharmaceutical part, there's many drugs that cause this as a side effect. So if that's happening to you, you might have to go through the list, and anastrozole and all these estrogen blockers have that side effect.
On that note, with men and estrogen, let's talk about men and fertility. One of the I mean, it's definitely something I learned that was new. I think maybe I've heard it before, but when it comes to infertility, Dr. Levitt did a great presentation on it. And backing up, if you on Neil Rosier that presented also, he did a great presentation. We've actually interviewed him on this podcast. Please go look that episode up. It's a great hour, lots of good information in 1 hour. Dr. Levitt was on just a few weeks ago, same thing, lots of great information in an hour about, we started out as estradiol, not oral estrogen, not causing blood clots. But we morphed into many different subjects. Great information. Go check out that podcast with Dr. Levitt. But one of the things that she said is, and I don't remember the exact numbers, but I think it's over 30% of all infertility is caused by the male. So, and it's much easier to check the male than it is the female. So check the man first,
right,
when it comes to fertility. And she said stories how women have been through the gamut of fertility stuff, and the man's never been treated, and it doesn't,
or tested
or
for.
tested, or tested. And knowing our medical system, it doesn't surprise me one bit.
No, but it's a money grab in my opinion, because like she said you should rule out the man first before you do anything invasive to a woman. So why aren't we trying the simple tests first? And there's several places there could be a problem, but certainly, if you are in that position, It could be both of you, it could be one or the other, but she says she makes the man prove to her it's not him before she has any procedures done to the woman. And I think that makes a lot of sense.
It,
Why don't we start with the easiest thing and then move forward? And I think there's a lot of heartache out there that you have a woman go through all these procedures and then the fix was pretty simple, and it's very time consuming, emotional, and a lot of money.
yeah, I think that's the gist of it. That's why it's pretty easy to check a man, and it's not as much money. So that's probably one of the issues. Let's see, Jan. That kind of I exhausted my list. Is there anything else that you wanted? Oh no, I've got one more. Um, so Dr. Neil Rosier talked about GLP-1s are not
Mhm.
the magic pill that everybody thinks they are, and he did use the term magic pill. That is his quote. And if, for those of you guys that follow Janet and I enough, we've been talking a long time about GLP-1s, and they're not the magic that everybody says they are. Now, we do also say obesity kills more Americans than anything, and due to cardiovascular disease. And losing weight will help that. So whatever way you can lose weight, it's probably going to be beneficial. So if you get on GLP-1 and it works for you, you can tolerate it, then great. But get off it as soon as possible. You lose muscle mass and you gain the weight back. Many people gain the weight back after going off of it. And this was one of our concerns for a long time. And there's influencers out there that's saying, "Oh, well, I'm just going to recommend it for my patients for the rest of our lives, for the rest of their lives." That makes no sense to me at all. You don't have a GLP-1 deficiency. That's not what caused your weight issue. And we don't know the long-term complications of it. We do know some of them. It decreases peristalsis in your gut. It causes muscle loss. Um, and ultimately, you need to change your lifestyle long term,
Right.
and that's the key to weight loss.
Right. I think the idea that you're going to be on a product for the rest of your life to keep you from eating is not a healthy idea, because you need to address what's causing or why you're overeating. Is it just you don't know? Is it the foods you're choosing to eat? Get somebody that actually does know how to be healthy, help you with it. I just think there's so many providers out there just writing the prescription without giving any counseling on the right nutrients that you need. And then, like Shawn says, if you're losing 50% of your muscle, remember your heart's a muscle. I think long term, this is not going to be a good thing. I mean,
And then
that's an organ I do
right,
not
right,
want
yeah,
to be any way compromised, right? So that is frightening to me. And then on top of it, it isn't just that we're doing this for adults. We're going after our children. We're going after our teenagers. And we do know that the GLP-1 affect hormones like testosterone and lower it. So many people out there prescribing GLP-1s will give testosterone as well, which, okay, that's fine. You're replacing something that they need, but don't do this to a developing human. That's scary to me. This person should be laying down their tissue now for further life to be fulfilling and existing and thriving. To give somebody something like this now, to me, is a bad move.
yeah.
It's very scary.
Kids just, I don't think, should ever be in a
No.
GLP-1. And there's a lot of talk about how GLP-1s have other benefits other than weight loss, and I don't know what else they say,
Sure.
long-term cardiac function, all this kind of stuff. I don't buy it. I don't trust most studies. Um, Big pharma funds a lot of the studies, especially when it comes to drug therapy, and they're going to say whatever they want. Ultimately, I think we were created well, and we just need to give our bodies the right inputs: sleep, diet, movement, exercise, get outside, um, and give our bodies the right inputs. We don't need some drug to help us um, lose weight long term, especially. So, anything else, Janet, that you have
Mm,
notes of?
I'm sure we could be here all day, but
Oh, yeah, we could.
those are highlights. Yes.
Yeah, yeah, those are the big highlights. But it was a wonderful 3-day conference. And I can't say enough about Dr. Levitt and Dr. Neil Rosier for putting this conference on. Actually, one of the speakers too that was talking about thyroid, he's going to be on our podcast. I got to look his name up. I apologize. Dr. Henry Lindner, I think it's pronounced. Great presentation on thyroid. So stay tuned for that. He's going to be talking about thyroid on our podcast. So that pretty much wraps it up. So thank you for tuning in to Health Solutions with Shawn and Janet Needham. Tune in Thursday to our midweek podcast, 8 a.m. to 9 a.m. Pacific Standard Time. And thank you so much.